Okay. Thank you very much. Um, so, let me take so I'm going to talk about clinical trials very broadly, and specifically about the role of selecting populations for the trial and what bearing that has on specifically our inferences about the result of the trial once it has been conducted. A lot of it should be quite familiar and hopefully uncontroversial. So I'm going to start about just talking about clinical trials as tests of specific hypotheses, and essentially what happens when you unpack that hypothesis into its relevant causal components. And I'm going to argue kind of broadly that in many trials, at least, the real unknown is not so much whether an intervention works per se, but specifically under what conditions it works, or what are the conditions under which an intervention is effective, rather than whether an intervention is just effective simpliciter. I will then obviously have to then give us a brief note on what I mean by effectiveness. And then I'm going to talk about the case. In the case I'm using is ECMO, which is extracorporeal membrane oxygenation, and I will tell you what that actually is, which was mentioned, or pediatric ECMO was mentioned in a paper by Worrell, but it doesn't tend to come up in philosophy of medicine a lot. Hopefully it'll come up more because it's pretty cool and quite unusual in medicine in general. And then I will make some broad claims in my conclusion, which I will hopefully have substantiated by the time I get to them. Oops. So, section 1. What are we actually asking in a clinical trial? Quite often it's not obvious from what people write in papers what exactly the hypothesis is. So you have things like this. These are all from separate trials, but essentially to assess whether survival could be improved, whether a certain drug can improve the efficiency of another drug in improving the symptoms of a disease, and if a trial succeeds or fails. So in this case, the implementation of VA ECMO in a specific disease, a cardiogenic shock, did not improve clinical outcomes. So kind of broadly, right, the standard hypothesis seems to be of the general form that, does an intervention X improve outcomes in a disease? Or if you want to unpack that slightly, for a binary outcome, does the intervention X reduce the incidence of the outcome in some pre-specified population, pre-specified percentage of a population with that disease? And then you have to further specify exactly what that population is. Usually it's explicitly defined according to inclusion and exclusion criteria in a clinical trial. So they will say, we only recruited adults above the age of 18. Sometimes you only recruit men, sometimes you recruit women as well. Generally, there are more trials in adults than children. And then what exactly do you mean by that disease? How do you define that disease? And what are the criteria you're using in order to define it? And those tend to be the explicit criteria. But there are also implicit criteria in the sense that whether or not it's a single center or multi-center trial, whether it's done in the developed or developing world, when the trial is done. So the trial is done during viral pandemic that will have bearing on what the kind of outcomes are, and specifically what the population is that went into that trial, even if that is not specified in the inclusion and exclusion criteria. So all of these things lead to a specific group of people who are being intervened on, and those characteristics, the characteristics of that group will have obvious bearing on what happens to them when the intervention is employed, right? And then if the trial is successful, usually it's because the intervention group has a lower incidence of the outcome than the control group, assuming that the outcome is bad, or some overall reduced severity of the condition. And then when that happens, we tend to then collapse all of that detail into a very glib claim that X is effective as a treatment for D, right? And then that's the thing that actually goes out into the world and is exported often fallaciously. So what happens when, but there are actually more to unpack here. Right? So this standard hypothesis does intervention improve outcomes proximally. So statins inhibit the enzyme HMG-CoA reductase, which is the final common pathway in the production of cholesterol. That is the mechanism of statins, right? We're not talking about do statins prevent heart attacks. That not at least within biomedical medicine considered the mechanism. The mechanism is what does it do to an enzyme in the human body. We also have the disease. So how does the disease cause the outcome? So cardiovascular disease, how does cholesterol form plaques in arteries, which block off the arteries and cause heart attacks and strokes? And then we have a further hypothesis, which is how does the mechanism intervene on the disease to prevent the outcome? And quite often, at least in modern current clinical trials, we have really good understanding of all of these causal components independently and prior to the trial being conducted in the first place. So if we know all of these things, it's interesting to just wonder why we are doing the trial, right? From Duhem-Quine, the results of the trial bear on all of the components of the hypothesis, but we have different degrees of confidence in these different components going into the trial, right? So the way that we are informed by the trial will vary, because if we have a very high prior probability for AB, but not the C, then plausibly the results of the trial will inform us more about C than A and B. Oops. And so, yeah, so if we do a trial in a situation where we have robust, good prior knowledge of the mechanism of the intervention, the mechanism of the disease, and also how these two causally interact, what are we actually getting out of the trial, right? And that's why I think population selection is interesting. It's standardly understood as grounding external validity, but I think there's more to it. So assume we know how the intervention works, we know how the disease works, and we know how the intervention influences the disease. There are still ways that we can then conduct a trial in an intervention which we think is an effective cause, which is a cause which intervenes on the disease to reduce the outcome. and yet still have a negative trial, right? So think about penicillin. We're all pretty happy that it is a treatment for certain bacteria, Streptococcus, and that bacteria cause sepsis. Sepsis kills people, and so antibiotics are given as a treatment for sepsis. And then that is not on the basis of clinical trials, right? That's just on the basis of causal reasoning and common sense. But you could potentially do a trial in late sepsis. So sepsis causes a systemic inflammatory syndrome. It causes multiple organs to fail. And if you leave it long enough without giving antibiotics, you will get a patient who are in extreme shock. And if you give those people at that point in time antibiotics, they are moribund anyway. So most of them will still die, right? You will have passed the point at which sepsis is reversible. You will have a trial with the outcomes showing little or no improvement in the intervention group. For penicillin, in a penicillin-sensitive bacterium causing sepsis. You may also just have a very heterogeneous population, right? You have all comers to hospital with fever or some kind of systemic inflammatory syndrome. There are many other causes of fevers and systemic inflammatory syndromes other than sepsis. Viruses, malaria, all of those kinds of things will cause very similar clinical pictures, but will not respond to antibiotics in the same way. So if you did a trial while including all of those kinds of people, you would again have a demonstration of low efficacy. And in those trials, you might be led to the conclusion that penicillin is only a marginally effective treatment for sepsis, and that would be bad. That would be a bad thing to do, I would presume. And I would also hope that the medical community in general would look at such a trial nowadays and not assume that we should not be giving penicillin in sepsis. But why? Why? So it seems like people know this stuff, right? That population selection is about external validity. That if you demonstrate that an intervention is effective, that you're only really demonstrating that it is effective in that population, so in the population which meets the inclusion and exclusion criteria of the trial. But furthermore, you're actually only potentially demonstrating that a treatment is effective in people meeting those inclusion and exclusion criteria in that particular place that the trial was conducted and at the time that the trial was conducted, because some interventions that are effective in one person today will not be effective in the same person tomorrow, right? So asthma treatments might be more effective in the winter than the summer in people who have allergies to pollen. Same person, different time, and the treatment will be inconsistent in its effectiveness. But if we time index our population criteria, or if we're so rigid on what we count as, or if we're so strict, then we potentially will have no external validity at all, right? So we will only say that the trial was the intervention was effective there, but it's never going to be effective ever again because we can never fully reproduce that population. So the question arises, and this is really the big question, what are the necessary and or sufficient, or what are the conditions which enable an intervention to be effective? What are the enabling conditions? We're not, on the whole, in general, if you look at a lot of trials, interested in whether or not a drug affects an enzyme. And we're not really checking whether or not cholesterol causes heart disease. What we're really quite often looking for is this: under what conditions do all of these causal processes line up? So yes, brief digression on effectiveness, right? So by effectiveness, I mean the degree to which an intervention is successful at bringing about desired results. So if you have a binary outcome, death is bad, we don't want that. But you might have diseases which have a severity scale. And in those cases, we kind of create a binary by setting arbitrary thresholds. There are problems with both of those kinds of things, but essentially all we mean is you pre-specify a result, and intervention is effective to the degree that it brings about that result. It's often taken to be an intrinsic property of the intervention, right? And you can see that because when you have a series of negative trials, quite often that intervention is completely discarded. It is never seen in the medical literature ever again. And if you want examples, we can do that afterwards because I have a whole slew of them. However, this is happening even though it is well recognized that what is effective in one population may not be effective in another or in the same population later in time. So it's possible to think of effectiveness as perhaps a dispositional property, and interventions are generally thought to be inherently causal, in which case, as Nancy Cartwright has told us over and over again, interventions are only effective under certain stimulus or enabling conditions, and those enabling conditions which we are often the most ignorant about. And population selection, to a large extent, represents a hypothesis about what these enabling conditions are. It's the question of in whom or under what circumstances will this intervention lead to the desired results, right? But this is a problem, right? Population selection is meant to maximize signal to noise ratio in a trial. You want the trial to show a positive result. So you want your population to have the best chance of responding. So you want them to be relevant. You want them to exhibit the kinds of things that make them susceptible to the intervention. And you also want a relatively homogeneous population, because population heterogeneity dilutes the signal, leads to a lower chance of showing positive results without ever changing any of the causal nature of the intervention. But if you have a very specific, very homogeneous population, given that the trial results only license that intervention in that very specific homogeneous population, then that reduces your warrant to use the intervention more widely or outside of that context. So generally in trials, you find very heterogeneous populations, which are quite irrelevant. And that's why we quite often see, especially nowadays, lots of negative trials. So how do we do this? We usually know quite a lot about the mechanism of the intervention and the mechanism of the disease and the pathophysiology of the disease, and we have ways of kind of linking up the two. And then from that, we propose conditions under which the mechanism will intervene on the disease to prevent the outcome. And then that goes into our population selection criteria, and then clinical trials are basically a test of this prediction, that under these conditions, this intervention with this mechanism will intervene on this disease with this mechanism to prevent this outcome. Which means that in the case when a trial fails to show a positive result, and we're very confident for other reasons, we have preclinical trials, biochemical laboratory research about the mechanism of the intervention, the disease, and the way that they interact. The most reasonable interpretation would not be to say that the mechanism of the intervention is faulty, or that we don't know as much about the disease as we thought, but that we just did it in the wrong people. Right? Something was missing, that the enabling conditions were not there, or there were disabling conditions, which meant that the intervention on that disease did not lead to the outcome that we expected. So this is a particular case in which I think this happens, right? So this is VV ECMO, so veno-venous ECMO, which is essentially a procedure where in severe respiratory failure, so we know that you need oxygen to live. You get oxygen through your lungs. If your lungs fail, can't oxygenate your blood, and you die. And there are a number of conditions which will cause your lungs to fail. And in those conditions, if only we could oxygenate your blood some other way, potentially you would survive. So that is what we do. You put in essentially two cannulae, two pipes into two big veins, or two pipes into one big vein. Take the blood out, put it through an oxygenator, pump it back in, you've got oxygenated blood. The history comes from cardiopulmonary bypass, so heart surgeries where your heart isn't functioning and you need to take over the function of your heart and your lungs at the same time. And outside of cardiopulmonary bypass, it was the early kind of work was done in pediatric populations. And Worrell, in his 2004 paper on randomization, talks about pediatric ECMO. And specifically, he kind of paints this picture where, ECMO in effect takes over the function of the lungs in a simple and relatively non-invasive way, which I will show you why that's an amusing quote. And in pediatric patients with a condition called persistent pulmonary hypertension of the newborn, the mortality is incredibly high. Without ECMO, mortality is reasonably low. With ECMO, so it seemed obvious that these kids should get ECMO, but the medical community at the time felt that they needed to do a trial, and the trial subsequently showed positive results. And the question is whether we needed a trial, especially a randomized control trial at all, when we knew perfectly well that this was a good thing. Right? So the ECMO researchers were forced to perform an RCT, right? We were compelled to conduct a prospective randomized study, despite the fact that their experience had already given them a high degree of confidence in ECMO. Now, when Worrell says ECMO takes over the function of the lungs in a simple and relatively non-invasive way, this is what ECMO looks like, right? There is nothing simple about ECMO, and it is the most invasive thing that we do in intensive care. It is very labor intensive, it is extremely costly, and back when this trial was done, the complication rates were incredibly high. So it was not as simple as, we know that this works, we should just give it to everybody, right? You really had to justify this. And that can be quite difficult to do, especially because ECMO is not a therapy. It doesn't improve the function of the lungs, right? It only supports the other organs while the lungs are non-functional. So the lungs have to recover or be recoverable or be injured because of a reversible condition. Right? It is extremely expensive. It is extremely labor intensive. It's highly invasive. And the underlying pathology must be reversible. If it's not reversible, then you are just supporting a baby on all of this for an indefinite period of time before they die. And that is pretty terrible to have to do, right? Death on ECMO and death off ECMO are not equivalent, right? This is very uncomfortable. This is very difficult for families to watch. And so you would not want to do this unless you thought that something could be done to reverse the cause of the respiratory failure. But this was in kids, and actually we had quite a lot of good results from the early trials in ECMO in the pediatric population, and it was rolled out quite widely. And then it came to doing ECMO in adults, which has actually been a very different prospect. Right? So we have essentially only 4 big randomized control trials in ECMO. First one was in 1979, comparing patients on mechanical ventilation versus ECMO, no difference. We then had a trial in 1994 with a lower volume ECMO, which was just supposed to be less invasive, therefore fewer complications. In 1979 and 1994, ECMO was in its infancy technologically, so there were lots of complications. People had to have blood thinners, anticoagulation, so that their ECMO circuits wouldn't clot. They would bleed. It was awful. It was expensive. And it generally did not seem to make much of a difference. Then we had H1N1 in 2009. ECMO was used in the viral pandemic, the H1N1 viral pandemic, where we had a majority of young patients with a self-limiting respiratory illness that was supported on ECMO, got better, got home. It was amazing. Everybody now wants ECMO. Right? But that was only in a specific context, which is a viral pandemic, which has never occurred until, drum roll please, 2020. But just before COVID, we had the publication of what was supposed to be the definitive trial in ECMO, which was EOLIA, which showed an 11% reduction in 60-day mortality in favor of ECMO, but this difference failed to reach statistical significance. P is 0.07. Alex will tell us all about this soon. This is supposedly a negative trial, which does not show that ECMO is effective in, again, mixed pathology respiratory failure. Yet if you look at the trends in ECMO use, first of all, pediatric ECMO use is decreasing, and adult ECMO use is increasing exponentially, right? Following Caesar, which was in 2009, there is an inflection point, and more people are being put on ECMO with no additional RCT evidence. Right? So either we've gone left, right? But this is funded. So in the NHS, this is publicly funded, highly expensive intervention, which under most circumstances would require a high amount of evidential support, right? But it does, the increase in use of ECMO does not reflect an increase in clinical trial evidence. There's lots of registry data, there's lots of historical control data, there's lots of observational data, but there are actually no good traditional standard frequentist analyzed RCTs in the literature. There are just other forms of evidence. So given the expense and the number of negative trials, right, these observational studies, which I don't think it's unfair to say are not regarded as the highest quality evidence, is, I would argue, insufficient to explain this uptake. Right? The uptake in ECMO is not as a result of the fact that we are doing more of it and therefore seeing better results in general. It's because we already actually know quite a lot independently of any of these trials, right? We know that ECMO withdraws blood, oxygenates it, returns it to the body. Nobody really disputes this. It's a machine. That's what it does. We're done. We also know that oxygen is essential to survival, not controversial. Nobody's disputing that. Right? And there are conditions under which we are unable to oxygenate the blood, and that kills people. We also know that it's invasive and costly. And yet, so Gatnani is quite a big wig in intensive care circles. And it's quite widely regarded now as unethical to withhold ECMO in the emergency situation. Right? As a rescue in the emergency setting, an RCT of ECMO versus non-ECMO in severe hypoxemia it's ethically unacceptable compared to one in situations such as CPR. Now that somehow we've reached this as a consensus, right? So my explanation is trials are not testing whether ECMO oxygenates the bloods with intractable, life-threatening respiratory failure. This is not what we are interested in, right? We know this. So what don't we know? Well, we know that when someone develops an illness and respiratory failure, they then go on to one of broadly three possible trajectories, right? If you go below the dotted, this is my, like, I can't do digital drawings. So, so if you go below this dotted line, you die. Prior to ECMO, everything below that line is invisible because everybody just dies. Now we can put people on ECMO and see what happens to their lungs at the point in which they would physiologically otherwise be dead. Some of them will go on to die anyway, either because their lung pathology is not reversible and we don't keep people on ECMO forever, or because their other organs fail, the organs we're not supporting, and those are the organs that fail and they die. Some people will have a reversible pathology and their lungs will recover, their lung function will improve, we take them off ECMO and they survive and they go home. And there are also some people whose respiratory function is declining, but are never actually going to decline below that dotted line. And so they would survive without ECMO. Now, we ideally don't want to put the alive without ECMO on ECMO because we're exposing them to an invasive, costly procedure that they don't need. We also don't want to put the people who are going to die on ECMO because we're exposing them to a costly, invasive procedure which they don't need. We somehow want to isolate that middle line, right? Who are those people? How do we identify them? And we can't wait until they're below the line because they'd be dead. And we can't do it just as they're about to reach the line because it might be too late. So we somehow have to be able to predict further up, preferably as early as possible, what they look like. Right? And this is our kind of so-called solution. We have prediction scores. We have one thing called the respiratory score, the REST score, which is supposed to essentially tell you how likely you are to survive on ECMO. Right? So these are meant to exclude the dead on ECMO people. And then we've got the Murray score, which is a severity score for respiratory failure, which is supposed to tell you to exclude the people who will survive without ECMO. So you have to be severe enough that you need ECMO, but not so severe that you will die anyway. And these have been kind of modified and multiply kind of changed. And when you actually make a decision whether or not to put someone on ECMO, there is a lot more that goes into the consideration, but is essentially about trying to figure out which of those three categories someone falls into. This is the inclusion and exclusion criteria for going on ECMO at the Brompton Hospital, right? And it broadly uses these scoring systems to try and figure out who it is. So this is where we are now with ECMO research. Right? We're trying to accurately select patients who are likely to benefit from DV ECMO for severe respiratory failure, as it's crucial given the low availability, substantial invasiveness, complications, high financial costs, and the existing selection criteria are influenced on interventional factors, including local logistics, how easy is it to get onto ECMO, how far do you have to travel, expert opinion, and data from observational studies, and a single randomized trial of ECMO, which was the H1N1, the CESAR trial. So the ongoing research interest for ECMO is how do we decide in whom? So how do we distinguish these three groups? How do we improve ECMO safety so that we have a lower complication rate? And how do we, there's a third one, which is the most controversial, which is putting the survive without ECMO patients on ECMO anyway, because we know that mechanical ventilation, if you put on a ventilator, is bad for you, bad for your lungs. And so if you put them on ECMO, you might be able to oxygenate people's blood without putting them on a ventilator. They would be awake, they wouldn't get all of the infections associated with it. But that has, at this point, failed multiply to show a difference. So, given, at least in this case, right, we have really pretty flawless mechanical understanding of what the ECMO machine does and how it does it. We know that respiratory failure kills you if you are able to oxygenate your blood. So I think that bit of the mechanism we're all pretty happy with. So there are many cases, and arguably many more cases than this one, where the bit of the hypothesis, that component of the hypothesis in which we are the least certain, is really just about in whom, right? In whom does the intervention work? Or what are the enabling conditions required for the intervention to be effective? Right? And this is really reflected in population selection criteria. And of the various bits of RCT methodologies that have been extensively analyzed and critiqued, this one does not seem to get as much attention. In which case, right, so one of the implications is that the failure of a trial to demonstrate efficacy does not indicate the lack of efficacy of the intervention so much as an ignorance of the enabling conditions under which an intervention is effective. So it's only in the limit case where we have shown that there are no conditions under which an intervention is effective that we should really be saying that this intervention is ineffective, right? It also potentially implies that interventions are not more or less effective. They are just effective in a wider or narrower context, wider in more or fewer people, or in a more heterogeneous or less heterogeneous population. And those two, I think, are significant things. And that's it.
Hello. I think that works.
Questions?
Thanks. I thought that was fascinating and a really nice way of framing some of the clinical issues that came up. I just want to, as we're trying to look at epistemology in these kind of areas, where you have a situation where there is kind of indication creep and there is, let's say, unsuccessful gatekeeping for certain interventions, then you run into this very problematic area where it's hard to do the trials that justify the practice that is ongoing, and it's hard to, and then you end up with sort of observation studies. And what you can also see, you see in an analogous situation like bone marrow transplant, is if you widen the indications for the intervention, then your outcomes will improve. Because if you start giving ECMO to less sick patients, then you're going to get better results. And if all you've got is observational studies, then you start running into difficulty. You can't really tell. It looks like you're getting better, but your population as a whole may not be improving. It's an observation box looks like a problem there, and you see these numbers creeping up. You can't feel evidence to justify that.
Yeah, so one problem is very much, if you put the survive without ECMO on ECMO, they will do well because they're going to survive anyway. And so part of the reason why we are now in, but the kind of ongoing research focus is looking at that population specifically. Right? Is ECMO better for you than mechanical ventilation? Right? Is the beneficial effect of ECMO also about mechanical ventilation sparing? There is you're right. There is definitely a momentum to these things. And there's a worry that we actually leave all evidence behind because we think that we know what we're doing when actually we don't. And yeah, I mean, bad evidential practices are just bad. I'm just trying to argue kind of in the sense that maybe this is not just bad evidential practice. I'm trying to push back against the idea that something like this would just be because we are no longer listening to the evidence, but actually propose that this might actually be reasonable because the evidence that we're using is just not the kind that we say that we need.
Thank you, Arjun. That was very good. I'm going to speak from experience as you are speaking, having cared for ECMO patients. There are a few things. One, I have concerns about the statistical significance and clinical significance that was found through the CSER trial, and other trials. A p-value of 0.07 in a momentous occasion of someone who you believe clinically will die. It seems compelling to suggest that would, although clinically not significant or statistically not significant, there would be a clinical significance there, allowing you to move forward with the ECMO intervention. As for, and I'm interested in your thoughts on that. The second part is there's context to ECMO management, and one of the issues that came up in the CSER trial was that patients who received ECMO in Britain, in the UK, received otherwise excellent therapy for acute lung injury. And yet it came out that there was apparent diminishment in, following of suggested protocols or proven treatments in patients not on ECMO, which may have contributed to the significant finding. And I'm interested in your comments about that, meaning context. If you don't have a great hospital, you either transfer to get a patient to a larger center with ECMO experience, or you put them on ECMO. How does that affect your clinical decision making?
Okay, so the first thing is that there's a lot of feeling that if someone has intractable respiratory failure, then non-ECMO means death, whereas ECMO means maybe not death. And wouldn't we always prefer maybe not death? But like I said before, dying on ECMO is miserable, right? So potentially, there is an argument to say that potentially saving one life and putting 9 others through hell may not be justifiable. Right? So the statistics don't necessarily work out that way, and that is genuinely why we need to know. In terms of the CSER trial and the p-values, so there have been post-hoc Bayesian analyses, which I know we all love, which generally showed that ECMO was beneficial not only in CSER, but also in EOLIA. So the EOLIA trial where the p-value was 0.07, there have been a lot of Bayesian analyses that have come out, which suggest that actually ECMO was beneficial in that group. It did from a just looking at numbers perspective, seemed to be that more ECMO patients survived. And that's where we get a lot of our selection criteria from these two trials. And then the third one, the thing that you said was about, oh yes. So in the CESAR trial, one of the critiques was that a lot of the patients who went into the intervention arm did not get ECMO, right? All they did was go to an ECMO center, which is populated by, specialists in respiratory failure. And maybe the reason that they did better is just because they were in better intensive care units. There have been a number of subsequent kind of analyses and smaller studies to suggest that that probably isn't the case, but like, I think that my kind of claim isn't so much that, it's just to suggest that we do characterize evidence-based medicine in a particular way, especially in philosophy of medicine. And this at least suggests that that's not how medicine sometimes behaves, even if they say, they don't always do what they say.
Thank you. That was really interesting. Thank you. I agree with you with your, could you put your last slide back up on that?
Yeah.
Yeah, that we're learning about conditions under which interventions are effective. The flip side of that, I suppose, is that you worry about special pleading for your favorite intervention, and you can make these kinds of ad hoc adjustments for your favorite intervention indefinitely. And I wonder if there's a bit more to be said, like if we are investigating the best case, or we have reason to think we're investigating the best case for a particular intervention, like if it doesn't work in otherwise healthy people with, who are good at
candidates,
things like that, then shouldn't we put things to bed? Shouldn't the conclusion be that this thing doesn't work, rather than, oh, well, we just haven't found the population in which this works, and surely there is some population that would respond well.
So I have two case studies. One is thalidomide. So thalidomide was originally a antiemetic for pregnant women, and we all know that turned out very badly. But actually, nowadays, it is a first-line treatment for myeloma, completely separate, completely unrelated, right? So if we are to just say that thalidomide is ineffective and put it in the bin, right? Why would we think that? We know that it interacts with biochemical receptors, it has downstream effects. So it does something. We just don't know what it does in whom, and in whom it will be beneficial in a particular disease. That's what we don't know, right? The problem comes with lumping this whole thing together and saying that the ineffectiveness in a trial bears in the whole set of the various kind of causal components of the hypothesis, and then we should just throw them all out at the same time. That's, you have to try and unpack things a little bit more and just figure out exactly which bit you think is unlikely to, where is it gone wrong? What's the actual bit of the story that we got wrong? And in the thalidomide case, we just got like everything downstream of the biochemical receptors wrong. The other kind of more general history of medicine case is that many traditional poisons, right, digitalis, aconitum, calabar beans, have all subsequently been found to be medicinal and are now used in medicinal practice. Right? The only thing that has changed is that we've gone from using it from persecuting witches to using it for anesthesia and and cancers and various other things. The only change is in whom, right? We haven't changed the actual molecular formula of the drug or the biochemical receptors that it interacts with. We've just used that kind of mechanistic knowledge to decide, okay, fine, maybe it didn't work there, but it might work here. So I'm just kind of trying to push back against what does happen, which is that you get 3 negative trials and the funding just dries up. Now, you can never test that intervention ever again.
Thanks. I like this way of looking at trials a lot, but I just wonder whether there's a bit of a tension in this selection view to the because to the extent that these selection criteria are well evidenced, surely a randomized trial is unethical. So there does seem to be a kind of a limit to the amount of evidence you ought to collect for a selection criteria and still carry out a randomized trial. Is that not a worry with this way of looking at things?
So I think, yeah, so if you have a lot of evidence that an intervention is going to be effective in this population, then at least you should not have a placebo control. That would seem, but the question is where is this evidence coming from? Where is the evidence for your selection criteria coming from? I would suggest that RCTs are one way of evidencing that. One form of evidence for the selection criteria are the RCTs. The RCTs are the evidence for selection criteria, that the mechanistic causal reasoning, because there are so many supporting factors, there's so many enabling conditions, the whole thing is such a huge mess, that quite often the only way of getting any kind of result that's believable is to run one of these trials.
That's a thing. I would say now that there still is equity between ECMO and that in this case, my impression is that there's still equipoise between ECMO and adequate acute lung injury care. So the CSER trial showed that there was significant improvement in patients on ECMO, yet the control arm, had this mixture of poor acute lung injury management and good lung injury management. So between ECMO and aggressive, appropriate acute lung injury care, there still is kind of an equipoise position. So the RCTs have not shown significantly that ECMO is beneficial. Some have, but there's been these concerns within the methods of the RCT.
I just, it's kind of a finger on this gentleman's question just here, which is, I would have thought as a biomedical researcher, NHS hospital director, public health policymaker, whatever your role, what you want is the cure to a disease. And the problem is, if you do a randomized control trial in a certain context and say, oh, well, it didn't cure anymore. Okay, well, it might cure people in different contexts. So let's do it again and again and again. So you end up saying, oh, well, it's not that it's not effective. We just haven't found the context yet. Well, I'm going to turn around to you and say, well, it isn't effective for my aim, which is it doesn't cure enough people. I'm not willing to spend millions, billions of dollars on a cure for just one person if in a very, very, very specific context. I don't really think that well, you can tell me otherwise, but I don't really think that's the aim of public health policy or biomedical research. So your use of the word effective, you just redefined efficacy, but it's not the way that biomedical researchers are actually using the word efficacy, which is it effective in achieving our aims of systematically curing people, not just curing people in a very, very specific context.
So I don't think anybody thinks that any intervention systematically does anything, right? I don't think this idea of cure is a thing that medicine is really invested in. There are very few actual cures. Most interventions we know only work in a few people some of the time, and we generally make probabilistic rather than absolute claims about efficacy anyway. The other thing is that there are lots of contexts which will include billions of people, right? So may not work in men, but it might work in women. That's still quite a lot of people. And that can be a widely different context. Changing one simple variable can also change the context dramatically and yet leave you with a very large number of treatable patients. And there's no way of knowing. So when we talk about enabling factors, doing a post hoc analysis of which specific thing was there or not there is very difficult to do, right? So quite often, what we recognize in these kinds of trials is that we don't know specifically which characteristic of the population was or was not the reason why this was or was not effective. And so now, especially so in COVID-19, we have these multi-platform trials. So you stratify patients prior to randomization. So you're essentially running the same intervention in lots of different populations at the same time, right? So you pre-specify multiple different inclusion-exclusion criteria, you randomize within those groups, and then you do subset analyses in a, what's the prospective way, right? And all of these are just basically, because what we're trying to do more and more is tease out these enabling conditions. Yeah, so I don't think that, yeah, of course we all want the cure for cancer, but nobody believes that there is a cure for cancer anymore because nobody believes there is one cancer, right? Or that cancer is one thing, let alone that there are cures for most, if anything. Like, I don't think that that's a thing anymore.
No, I'm not saying like universal sort of I have no problem with the concept. The problem I have with the use of the net. So why they have a sort of a very specific answer. What I say is as a public health policy leader, or someone who's responsible for investing, I think you can't use this valuable for the work of the content. I will say that it might be effective in context, but another factor will affect it. It isn't effective. My aim is to for health community, alcohol, or community support, that you provide you exceptionally expensive routes of semi-quality drugs. These are actually effective in the way that I'm effective as a biometric policy that we do not have money. Yes, it's effective in one sense, but it's not effective for my health.
Yeah, but all I'm saying is that, you know, everybody wants the widest possible context, right? Where everybody wants a drug to be effective in as many people as possible. But saying that efficacy can be divorced from that context is wrong because it's not, right? Efficacy is invariably contextual. Things are only ever effective given a certain context. Even if a cancer in terms of the cell is considered to be curable, there are lots of important curable cancers where you can give a chemotherapy agent and that cell will die. Those patients who have those cancers may not be curable because they may not tolerate the chemotherapy, right? So in that sense, their cancer is not curable. So that's all I'm saying is that We all kind of accept that the context matters, and nobody seems to really worry about that. I'm just saying that there are some interesting implications of that when we come to thinking about what do we do with failed trials? What do we do with failed trials? And I'm suggesting that we don't conclude that the drug doesn't work ever. And actually, we often do conclude that. And I think that's a bad thing to do.
We're out of time. Thank you very much, Arjun. That was great. Thank you for the questions. We will have lunch and then we should be back here at 1:20. So it gives you 50 minutes. Thank you.